everyone. We're going to go ahead and get started.
Yeah, Dr.
Oh, oh, wait, we have to
Yeah,
wait for
he
him.
just stepped out for a second.
Yeah, he's a quorum.
It's going to be challenging.
Okay, where did Emmett go? I'm going to tie everybody to the table. Oh, there's Emmett. Hey, Emmett.
Come over here.
Okay, there he is. All right, here we go. Okay, welcome everyone. We're going to go ahead and get started. Good evening. Today is October 8th, and it is 5:15. As a quorum of the Central Health Board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. We'll now receive public communication, which I don't believe we have any. No public communication. And so I'm going to turn it over to our chair for care. Go ahead.
Hi, welcome everyone. As is October 8th at 5, oh,
Yes.
sorry, hello, is that better?
Yeah.
All right. I would like to call the meeting to order of the Integral Care Board of Directors. It's October 8th at 5:18, and we have a quorum, so we'll get started. I'm going to take this opportunity to kind of introduce why we're here tonight and chat a little bit about that, and I'm going to turn it over to Ann afterwards. So, first of all, thank you. It's been a lot of work on a lot of people's parts, mainly you, putting this together, and I want to recognize, Ann and I both want to recognize all the work that you've been doing in terms of this collaboration to make Central Health and Integral Care even more effective in what they do in serving our community. Tonight we're going to be exploring a continuum of care, the collaboration that you've established, and we'll have a chance to discuss. We're going to hear a presentation, we'll have a chance to discuss, and we hope that we leave with a shared understanding of our opportunities, our challenges, and the path forward. And just to take a step back, thinking about why we're here today, Central Health and Integral Care's relationship goes back decades. And we've worked together on many facets and many issues facing the community. And over the last year, going on 2 years, we've really had an opportunity to deepen the collaboration and the planning in particular that goes on around behavioral health in the context of healthcare for our community. So we're just really excited to be here and have this. This is our first inaugural joint meeting. Yes. Maybe it won't be the last. But this is the first time for us to come together as boards and really speak to an issue that I know is near and dear to all of our hearts. So this is a very timely conversation, and because we are making advances, and I'm really looking forward to what we can do in the future, and I hope you are as well. So, Ann?
I would just add that I think we're all just really excited to be here. I mean, we live in a community where there are great needs in terms of mental health. And there are also great needs to collaborate and coordinate across our community. And we are two primary major entities in our community, and we have the opportunity and the ability to be leaders in our community, to look at the system of care for mental health across our community, to build one, to make one, to improve the one that we have, so that we're all working together, that we collaborate, we have synergies, we don't duplicate, we don't go off on tangents, we keep our eye on the ball of what we need to make this community the best it can be, to serve mental health needs for people in our community. So I'm very excited about this. I know, and I echo what you said, I know all of you guys and many more that are not sitting up there that have been working very hard on this, and this is just the beginning. There's a lot of work that needs to be done. It is not easy for entities to collaborate in a way that really gets us to a point where we're looking at the continuum of care, and we have a seamless continuum of care. And then from our perspective, we are most efficiently providing services in the way that works best for us all together. That's not an easy task. And we all want that. We're all on the same page in terms of the vision, but it's not an easy task, and we recognize that. And so really appreciate y'all's work. And we're here as board members because we want to support this effort. We want to guide this effort. We want to provide the resources that are needed for this effort. And so so this is a good conversation for us to begin. It won't be the last conversation by any means, but it's a good place for us to be, and we're just excited to see what y'all have come up with so far.
All right, so I want to introduce Pamela Benson Owens. Raise your hand. I think many of you are familiar with Pam. Thank you for being here with us tonight. Pam is going to facilitate the second half of our meeting. This first meeting is for us to hear from you, and then there's going to be a facilitated board discussion after we have a little break to get some food. We won't starve you while you're working. So I want to, if I could start real briefly, if our board members, if you wouldn't mind introducing yourselves, like real briefly, your name, what you do. Although Sally, we kind of know what you do. You're sort of a walking brand, you know.
She can still put it in her own words.
She can put it in her own words. Yeah. And then how long you've served on the Integral Care Board, and then we'll do the Central Health Board. Sally, do you mind starting? Sure.
I started serving on the board in 2017 or 2018 when the governor appointed me to the board or appointed sheriffs to the board. And so I'm glad to be here, glad to be part of Integral Care, and very appreciative of the relationship that I have with Central Health. So.
My name is Ed Callahan, and I've been on the board since 2017, I believe, 18, I believe. I am a pastor of church, or I've just stepped down as pastor of church, but I've been in community mental health business for many years, from state department to the local department. I'm just back home. Enjoy working. Used to be on the MAP board, too.
All right, hi everybody. My name is Sarah Churchill Lamas. I've been on the Integral Care Board since 17 or 18. I think I'm going on my 8th year completed. I'm a city appointee. My day job, I am the president and CEO of the Austin Healthcare Council, and I'm happy to be here.
Okay. My name is Emmett Hayes, and I hate that you all ask how long I've been on the board. I don't want to take my shoes and socks off. But I believe this is my fourth appointment, so I'm beginning a fourth term. So that's pretty good. And I still got some makeup. Oh, you still how many years?
Yeah.
Yeah, well, I was just assuming. But nonetheless, I retired from both the state of Texas and Travis County. I think my last known job with the state was with the Texas Department of, through the Texas Commission on Alcohol and Drug Abuse. And I wanted to mention that in particular because of the continuums of care that were built in conjunction with the Texas Criminal Justice, what was called then the Texas Criminal Justice Treatment Initiative. So I'm excited to see and to be a part of this development and implementation of what I'd like to see a seamless system of care. And so we keep hope alive for that. And of course, I retired from the Travis County Juvenile Probation Department, yet again developing a system of care for juvenile offenders. So I'm glad to be here. I'll stop talking now.
Thanks, Emmett. Trish Young Brown, I've been on the board of Integral Care 2019, I believe, something like that. I am a Central Health appointee. And as I mentioned earlier, I've had an opportunity to work with integral care when I was at Central Health on that side of the equation. And so just really appreciate being able to continue to serve the community and in these areas that are just so important. So thank you.
Okay, we'll now go around this side of the room. My name's Ann Kitchen, and yeah, I'll finish this and then I'll do this. Yeah, where did David go? Do I need to read this first? Okay, we'll finish. Okay, so my name's Ann Kitchen, and I've been involved in healthcare, mental health care, and physical health care for many, many years, starting as my work as a social worker. Most recently, I rolled off the city council 2.5 years ago. So I've appreciated the opportunity to participate on Integral Health Board for going on 3 years now, as well as the Central Health Board.
No, that's fine. Can you all hear me? Okay, great. Well, good afternoon, everyone, or it's still early for good evening. My name is Maram Musaitif. I am a implementation scientist and a public health researcher focused on cancer research primarily. And I've always been interested in health, and I believe mind and body as well. So we cannot treat one and neglect the other part of our body. And I've been on this board for a while. I think I'm in my 2.5 term now. So it's been a privilege to be on here and doing the work. Thank you.
Hi, I'm Manuel Martin. I'm a local physician. I used to direct the emergency room at Seton and Brackenridge and ran the residency program. As such, I got exposed to a lot of untreated mental illness. I'm currently on the faculty at the medical school at UC Dell and UTMB, and I've been on the board since, seems like forever. Maybe 3 years, 2 years? 2 years.
No, more than that.
Okay, 3.
Yes, okay.
Thank you.
Okay.
Hi, I'm Amit Matwani, and I sit between giants, apparently. I have served on this board for just under 5 years, and career-wise, I began my career as a youngster in software, and shortly thereafter spent 25 years in nonprofit health and human services, from direct service delivery through executive management and board governance, and have found my way back into software, where I work at Bonterra Technologies, which is a social impact software company, and I'm supporting the development of a national platform for community violence intervention, data collection, which is rooted in justice reform. So there are some giants in the room there as well, who I'm sure are very familiar with the work. Honored to be here, and very keen to get into the discussion. The backup materials look great.
It's almost evening, but good evening. I'm Shannon Jones. I'm currently in my 8th year as a member of the Central Health Board of Managers. It will be my last year. In fact, my term ends in December, and so I've decided not to seek reappointment. I served as the health director for the city of Austin and Travis County for several years. I've enjoyed my experience here and still plan to be involved and engaged, but I think it's time for me at this point to take a leave and take care of things that I need to take care of, but I look forward to continuing to work with the community as a whole.
All right, we're now going to take up item number 1, which is to receive an update on the mental health system of care for low-income and uninsured people in Travis County.
All right, I think this is the Pat, Jeff, and team presentation.
Jeff and
right?
Pat.
Okay, so Jeff and Pat and Jeff, however you want to look at it. But we look forward to your presentation. I assume we're going to hold questions to the end, so you can just breeze through things. We'll take notes, and we'll have time to ask questions after you're finished.
And our goal for everyone around the room is, if we can, we'll shoot for getting to the second part of our agenda, which is the discussion around 6:45. So, thank you.
Wonderful. Well, Jeff has promised us an interpretive dance if we get done before 6:45, so we should all strive for that. And, it's an enormous privilege and honor to be here together with my colleagues from Integral Care, Community Care, Central Health, and so many more, as you all have referenced, who have contributed over many, many months to work that is continuing. We're not done, but we are delighted to be able to share with you all tonight where we are so far. And we're excited by where we are so far because this is difficult. There are deep fragmentations in our space that all of you are well aware of. Those fragmentations create risks and harm for our patients. Mr. Hayes, if I could echo your comments, a seamless journey of care, keeping hope alive, right? That is what we are about. Our patients need to be at the center of this conversation. As much as we know in so many ways we have separated physical health from mental health, the mind-body connection, Dr. Musaiti, right? There is no health without mental health. It's easy to say and not so easy to do. And so what we want to do tonight is present the very first early draft of some integrated thinking around how to keep hope alive. And in the interest of time, what I will invite everyone to do is when you end up speaking, please introduce yourselves at that point so that we can reserve as much time as possible to move through material and ensure there's time for questions, and then we stay within our limit and we can all watch Jeff do his interpretive dance. Next slide, please. We chose to frame the problem statement appropriately around patients and fragmentation. So individuals with behavioral health needs across integral care, community care, and central health, and by the way, outside of these three organizations as well, though this is a good place to begin, may experience care that feels disconnected at times, and I'll add, is harmful as a result, and maybe even fatal as a result. There are deep injustices that we have to solve. Strengthening coordination among providers offers us an opportunity to reduce duplication, ease transitions, and improve timely access to support. Reducing that fragmentation will above all improve care. It will also improve the experience of giving care, which is very important. There is moral injury, moral hazard. It hurts to not be able to care for people the way that we know is right. And this is also going to be better stewardship, wiser stewardship of taxpayer dollars, public resources, state dollars, federal dollars, and so on. We have a duty to deliver exceptional long-term value to the public, in our case, Central Health, to Travis County taxpayers. And that is always in the room as well. And so we believe by making care more connected, we can take better care of people, we can reduce the moral injury, and make it better for those providing the care, and we can deliver greater value to the public. And so with that, let me hand over to Jeff. Go next. Please introduce yourself, Jeff, as you get into this.
Introduce myself?
Yes.
Hi, everyone. Again, thank you. Thank all of you for your time. I mean, we are living and breathing this, and you all are volunteers, and we appreciate your dedication to helping us keep on track to do this. Pat might not remember this, but actually, right after I accepted this job, I looked him up in LinkedIn because I said, yeah, this guy's starting about the same time I am. And I immediately texted him and said, you and I are going to be very good, close friends. And he may have thought that was a little creepy in the beginning, but it's actually held us, and I think that's really, you'll see a lot of goodwill amongst both of our teams on working this stuff out. But to echo what Pat said, this isn't easy because funding, policy, the universe, we're swimming upstream with a lot of this stuff. And so us coming together is important. The other piece of this, and then I'm gonna dive down about 7 slides, which I think does a better job of explaining this system of care and then come back to this, is that we're at a time where funding at the federal level, at the state level, I'll use the polite term, is a little kerflooey. We have a hyper-focused local model here that can really be a model for other places. And I really mean that. I think we have a huge opportunity to interconnect, central health, integral care, community care, all of us really working really closely in a way that I think other entities may not have that opportunity. So that goodwill aside, let's jump into it. If you move down, I'm sorry if it's probably one of the last slides in there that it looks purpley like this. And if we could move the slide deck to that one. And I just wanted to start with that, just because it does a better job of explaining this to you all in terms of kind of what we have been talking about some of the critical ingredients to this recipe of behavioral health services here in Travis County. And I'll go through these quickly in the interest of time because I know you guys have this and we'll be talking about it throughout this discussion today. But really, when we've talked about what's important in Travis County, there's both services and then the structure about how we move this work forward, which is really important. And these aren't in order of importance, they're all important. But on the first on here was around governance and coordination. And so part of the work that we've started and will continue to develop is a more governance and coordinated way about how we deliver this work, how we coordinate our efforts, and how we work with other partners to help us do this in a coordinated fashion, how we make decisions around what services are and who's doing them, and doing this in a much more collaborative governance fashion amongst all of our teams and other partners, not just us at the table. When we talk about integrated care networks, we'll be talking about that in a moment, about sort of the clinical model about how we want to approach this work around sort of levels and areas of quadrants of focus that each of us will have in this work. But it's also really how well and how successful we integrate all of these things together. And, central health teams, community cares team, integral cares team, and others. And about how do we not just create really high-performing silos next to each other, but how do we create much more of an organized logic about how we create this system of care. With that, there's lots of other things that really will make that work. Here, one of the things I would love to be able to do, we are moving, there's a lot of emphasis right now on crisis care. And part of that is that we have not invested sufficiently in preventative care, but there's still a deep need for more crisis-based services in Travis County. And we've talked a lot about those already around mobile crisis teams, sobering centers, our services in the diversion pilot. But there's also things around inpatient capacity. And how do we actually work together to ensure that this continuum of care includes inpatient capacity that will help meet the needs of these most vulnerable folks in our community. And I think we all here have a critical role to play in that. Because what we want to be able to do, a really amazing vision is if somebody is seeing someone in an inpatient unit, that doctor or that treatment team follows them in the community and continues that continuity of care around both medical and behavioral health services. Early identification and prevention. We are doing a lot within schools, but it's uneven based on funding and structures. How do we do more early intervention and prevention and screening services so that every child has access to those services early on, and specialty care in that space? We've spent a lot of time already talking about, particularly around folks with autism, and how do we work early on to be able to identify and link people to care. Housing and health models. This city, and actually Kirk Watson just posted something a little while ago identifying that for the first time, we've seen a drop-off in the homeless population. That's great, but our job now is to ensure that we help people maintain that success through clinical interventions and a continuity of services. I fear that we've done all this work in building housing, but we haven't finished the job because we need to help make sure people maintain that success, and through medical interventions and behavioral health ones. And there's a full continuum that we have here, but it's not at scale. So a lot of the work we have to do is how do we ensure all of these services are at the right scale for this community. Equity-focused workforce. So again, how are we ensuring not just our workforce, but our community has full access, regardless of who you are and where you live? And so regardless of all the political noise right now, our obligation continues to go deeper, and we have to reach farther in to make sure that that happens. And that includes recruiting and retaining the best of talent to be able to deliver these services. We in this community have talked a lot about justice and justice-involved services. Our sheriff is here, and she and I talk about this regularly, about how do we make not the most widely utilized inpatient facility being the jail, and move it to actually more of clinical services and help ensure that people can be diverted successfully. We're all we've gotten incredible support from Central Health to expand a lot of our diversion pilot, but now it's taking this forward and doing this at a much deeper scale and working with partners beyond the folks we're working with now. When we talk about community-based recovery supports, people with lived experience are at the very heart of this work, and how do we ensure that they are helping us inform the best practices to deliver this care? This is one that people start to glaze over when we talk about it, but it's a really important one, which is how do we create a very well-developed data sharing process? How do we share information so that as Pat was talking about in the very beginning, people don't endure the same torment that we make them go through at every point of their journey of care. And how do we ensure that we share information in an effective, efficient way? We have the pipes to do this. Now we actually just have to connect them and work out the logic. We are at a good place. We have good bones in this county, and you and I have talked about this many a time. But now we need to take this forward and use us as a model to be able to link and develop those connections. And then last but never least is how we finance this critter. How do we make all of this work? How do we leverage what dollars Integral Care can pull down from the state as being an LMHA? How do we leverage the incredible power that having a FQHC here, being able to leverage the federal dollars and things like 340B pharmacy programs. How do we make that work for everyone in this community and do it in an aligned way? Being able to do this in more flexible funding that follows the person, not the complex models of grants that many of us, the Integral Care Board knows we have 200 sources of income to deliver the services that we have. And it's a very complex system to be able to do this that doesn't always align with the goals that we're trying to accomplish. And so we're going to knock this off by next week, and then we're going to phone in the rest from here. So I'm going to go back to the top again, please. You guys still with me? Okay. This is something that our teams worked on, and I'm not going to go through this in depth, but no, we just went through this list. There is a lot of progress we have already made in this in terms of work that we've been doing together. There's much more to be done, but we have started across the board doing some of this work, from governance to integrated care to our continuum, and that's not simply funding and support. It's around how we're actually going to work on handoffs, how we're going to look at data, how our teams can more collectively work together. But we've really just gotten started. Next slide. So this is one that I could kind of nerd out on, but I'm not going to. I'm just going to kind of give you the general overview of what this means. This is, in essence, we call it the four-quadrant model. It's been around in terms of a design. There's nothing earth-shattering about this, but really this was set up probably in the late 1980s, early 90s, to really talk about how people should get care. And as many of you said, how do we fully coordinate the brain and the rest of the body and make sure there's a well-coordinated system of care between behavioral health providers and behavioral health services and medical services and primary care? And how do we build a model of services that actually matches people's needs, right? Wouldn't that be something? But when we start talking about this model, if you look at it from the very top left corner, this is really broken up into two domains. One is in the clinical, the behavioral health acuity level, the high needs and the need level of someone with behavioral health needs, and also on the high to low or the low to high needs on someone's medical complexities. And how do we look at systems of care that match and can design and coordinate those services in a logical way? And so part of that will help inform us as we look at designing and coordinating a system between our entities here. And so if you look in the top left, for example, if somebody is coming, ideally, if someone has a significant behavioral health need, that locus of service would probably be in the behavioral health provider. But in that space, there also would be well-coordinated primary care services and access to screening and more substantial linkages to care. And as Pat will talk later, and as our whole team, what we're trying to do within our system is create a flow between this. So if somebody, for example, if I come in as someone who's struggling with a severe and persistent mental illness, and my medical screening identifies needing more significant medical care, how do we ensure that those systems are well coordinated and link that person to a system? But that locus of service provision happens within the behavioral health sphere, not necessarily in the primary care universe. And so if you look to the far right, when you look at quadrant 4, that's with someone who has both a high behavioral health need, but also a high primary health and a medical need. And where someone is struggling with major significant comorbid medical and mental health conditions. And so that's where some of the work that we're also trying to sort out now, where if somebody has those needs, how do we ensure that someone can bridge and have access to help them be successful? Because one of the biggest challenges that we see is someone, particularly folks with schizophrenia, sometimes getting access to good medical care and having someone have good confidence and trust and have a good partnership with a medical provider and ensuring that the treatment happens and adhering to it is some of the work that we see. We have a lot of folks that who die typically 20 years less with a severe mental illness because of a combination, very little to do with their illness. It has more to do with access to care and coordination and adherence to medical treatment services. So if you go back down to the bottom left, that's really someone who's struggling with kind of a low behavioral health need and a low primary health need. And in that case, a lot of the primary care services can do both the behavioral health screenings and also the medical access. And that's one where having an incredible partner like community care is critical. And what we find is that people don't stay in these boxes, right? People move back and forth. And some of the work that we're trying to sort out more effectively with data and systems is how do we help people move across these domains more effectively? And then if you look at the last in the lower right corner, if somebody has a low behavioral health but a high medical need, again, the locus of that care is in the primary care universe and in some other medical facilities. But this is where we're trying to break through and create a secret sauce here that other places. Wouldn't it be awesome that if we had integral care clinicians working across these domains and community care clinicians working across these domains, so we can ensure that that care gets bridged and all of this continues to coordinate regardless of where your needs are at any given time. And I think we can do that. But what it means is that we're going to have to solve for this and how we organize services, and how we approach this work very differently, which has been, as Pat said earlier, we've all been in pretty high-performing silos with this work, and occasionally we bump into each other. And it's now, how do we take this forward? And as you'll hear in a little while, how does it look when we start taking that apart when we look at patient journeys, and how can we effectively do this? I'm going to hand this back to Pat.
All right, so next slide, please. So with the caveat that all models are wrong and some models are useful, please keep that in mind. But what we're trying to do here, you see the same labels, quadrants 1, 2, 3, 4, as the previous slide. So if it's helpful, you could even put that previous slide side by side and imagine that we're overlaying. And the reason we did that is that 4-quadrant model is a well-established sort of national best practice, and we wanted to make sure we're anchoring to that framework. But then as we kept on playing with this, and this is months of conversation and back and forth, we realized we could maybe, put our 3 organizations on this map, and we could maybe represent the islands of care. So that's what you have here. You have 3 islands of care. And of course, it's not as simple as that, and there's no intent for the exact spacing to be representational in terms of service to dollars. It's just it's a model, right? And there's space in between the islands of care that right now patients have to swim from island to island. That's hard to do. It's not safe. Some folks don't make it. Some folks get hurt. Some folks die in that space. So that's kind of the setup here. And what we're going to do is Jeff's going to talk through the Northwest Island of Care. Nick will talk through the Southwest Island of Care. And I'll talk through the East Island of Care, very high level at a systems level. And then we're going to dive down and take it at a patient journey level. So Jeff, Northwest Island of Care, system level. What's going on today, and what's missing? Like, how do you feel that that disconnect from that island?
Yeah, I think I touched on that a moment ago, which is really this notion that we, our structures aren't necessarily matching patient need. They're matching our financing need and our policy needs, and not necessarily ones that actually line up with actually individual needs. But what we have, one of the things that our Integral Care has done a really amazing job is build out a range of behavioral health services. But what we haven't tackled here, and this sort of ties into what we'll be talking about going forward, is any of our system, no matter what domain that we feel we're all nested in, it's not necessarily logically built from the ground up. And so our services, as I said earlier, we are very focused on the population we serve. We serve about 35,000 people a year. That's not entirely unduplicated, but we have a large portion of the folks we serve with severe and persistent mental illness who use multiple behavioral health services within our system. Their medical conditions are pretty significantly poor, some of which is because it's been untreated, and some of whom have not a high degree of trust of their medical care. And so what tends to happen is we do our best to link people to care and coordinate that, and we have a lot of overlap. But a lot of our domain historically has been in high-end folks with severe and persistent mental illness. But the other thing it's worth noting is that many of the folks that we serve also, because of our structure, we are the safety net for those services, meaning a large portion of the people we serve have no insurance whatsoever. Where we've struggled, and I think we continue to, this becomes a challenge not unique to us, but when somebody doesn't need that level of intensity, but needs ongoing maintenance of effort and support, where they could have that work being supported in a primary care setting like community care. And that opens up access for folks who need that high intensity care. We haven't always built that logic model within our systems. So, but I think we have such an upside here, guys, to do this.
Thank you, Jeff. So Nick, and if you wouldn't mind introducing yourself as well, Southwest Island of Care. current state? What are the opportunities here?
Hi, everyone. I'm Nick Yagoda. I'm the CEO of Community Care and the Executive Vice President for Ambulatory Services for Central Health. I've been with Community Care 11 years, and watching the behavioral health footprint in our primary care and specialty services evolve over time has been really instructive, and I think speaks to a lot of what Jeff alluded to. Where I want to double down on one of the things that Jeff said, and that is the extraordinary breadth of sophisticated services for extraordinarily complex mental and behavioral health services that Integral Care does. Stands out within the community as really the only place that is able to function at that level of expertise. And to use an old sort of well-worn analogy, they go, with those really acute patients, they go a mile deep in the complexity that they're able to support. At Community Care, we're sort of the opposite, more of an inch deep and a mile wide. We have a very big footprint in terms of number of unique patients seen, to about 150,000 this year. And true to the point that have been brought up, everyone who comes to visit Community Care with a health condition has some level of behavioral health, mental health needs at the same time. We are undoing legacy structures of U.S. healthcare that separated the brain and the mind from the body for time eternal, and it's not easy to undo. There's a tremendous amount of stigma even to just talking about mental health in the first place, even when you are at a stage where it's not as immediately evident or disruptive as you might see once they get to the acute level at Integral Care. We have yearned to partner with each other in deeper and deeper ways, and we have fought the streams of different electronic health records and entry systems and funding pathways to the extraordinary frustration of our patients, of our staff. And so the opportunity now to see that primary care can cover an extraordinary expanse of healthcare, that the breadth is really unusually large. If we can then tap into the depth now that the partnership with Integral Care allows at a greater level, the returns are far more than promising. I will tell you there are instances where this has happened, and it's breathtaking the change that can happen with patients. I would tell you many of those instances are based on personal relationships of a team or a provider at Integral Care and at Community Care who call each other on their personal phone lines and just make something work. That is unable to support the sheer burden of mental health that we need. So finding sophisticated avenues to connect our services that don't rely on simply the goodwill of friends or strangers, but actually on mechanical processes that just make it easier, better, faster, and ultimately cheaper for everyone.
And then Central Health on this page, we are the Chapter 281 hospital district. We have a statutory responsibility to ensure the full spectrum of care is delivered. And for many years, as you all are aware, we planned for, we capacitated, we paid for, and supported care. And we are a relatively recent entrant with the community's strong voice and the data support of where the gaps were, entering into direct service of that care. And as we create more direct service components, these islands, we are meeting partners as best we can where they are, with the sheriff, with your team, with EMS, different PSH services, respite, and so on. We are trying to find those gaps between the islands of care and build bridge services. We have a bridge clinic mobile service, 3 flavors of that. I won't go to all that depth, but if you look at our portfolio, it's a very unusual portfolio as a health system. We're coming from the outside in, from the bottom up, from what hurts patients the most, and where are the fractures the most acute, and connecting. It is a partnership model, deeply partnership model. University of Texas, DMS, Ascension, HCA. We work with everybody. We're throughout the turn of the fiscal year. I sign, 150 or so contracts with health providers throughout the entire system. You have 200 funding sources. We are the funding source for more than 200 partners in the physical social space, and we're proud of it because that is needed, I believe, to heal the fragmentation, and it allows us to get real proximal through partners like the Hungry Hill Foundation, where we earn trust through lived experience, in the creek bed from folks who have been there and know what we're talking about, and then we capacitate those partners with clinical operational support, so they don't have to build all that themselves. In this case, just to orient, if we imagine that these quadrants cover the entire range, on the far right, you might have somebody with an unstable heart rhythm, in severe sepsis, intubated on 3 pressors in the ICU, who is also schizophrenic and will need care the moment they get extubated and they can hold their blood pressures and oxygenate effectively enough to talk, right? In that setting, we still want to know that we're coordinated and we've got the plan for how we're going to blend in electroconvulsive therapy and get somebody safely all the way downstream, navigating maybe from the top right to the top left to the bottom left eventually through safe streams with data people and so on. So when you see Central Health on the far right, envision that us with our partners, the University of Texas, Ascension, HCA, et cetera, we have to provide the care or pay for the care, for the safety net population, that we are trying to ensure that we are visualizing the behavioral health needs, even at times when the physical health needs may be proximal and must be taken care of first. So that's why you see the island set up like this. And we're going to get deeper into this as we talk through the patient journeys to elucidate this, and then we begin to talk about what's it look like when there are bridges between these islands and there are more deeper integration and partnerships even of each other in each other's islands. So with that,
Pat, one other thing I just want to add.
Please.
I want to just echo the comments that both you and Nick have said, which is we count on the goodwill of our amazing staff to make this work, both in the service provision and mashing up these models. What we want to get to is a more systemic way to tackle all of this around both how we determine what services are available and what's the right place to deliver those, and also who should be building those services and under what model makes the most sense. And so we want to get beyond the incredible goodwill and build a more logic-based model about how we approach all of this. And so that's the work that we want to keep testing off of you all.
So with that, we are going to invite our clinical leaders from all 3 organizations to walk us through patient journeys here. And so, folks, as you take your turns, please introduce yourselves. And I believe, Ashley, are you going first here?
I am.
Is that right? Okay. Ashley Trust, everybody.
Yeah. Hi, everyone. My name is Ashley Trust. I'm a psychiatrist, and I am the Director of Behavioral Health at Central Health. So I guess we can go to the next slide. We're going to go through a patient journey, and this is really meant to highlight a couple of things, but one of the biggest things is to just ground us and root us in the humanity of the work that we're doing. While we talk about systems and how we're building them, these are people and people that we work with every day, and so it's just important for us to come back to that as we go through this. So that's first and foremost. And then secondly, this is to highlight how a person, when they're going through their mental health journey, how they actually go through each of our healthcare environments right now. Okay, so we're going to talk today about a 60-year-old female who has a medical diagnosis of, she has a very severe seizure disorder called epilepsy, and another disorder called myasthenia gravis, which is an autoimmune disease that weakens your muscles. Psychiatrically, she's been diagnosed with major depressive disorder, but there is some clinical work that needs to be done to make sure she doesn't actually have a bipolar 2 disorder. In addition, she has generalized anxiety disorder and has chronic thoughts of not wanting to be alive. And we call that chronic suicidal ideation. So this story starts here in Travis County in 2020. She moved here from California. At that time, she was able to find work, but she wasn't able to find housing. And as a result, she ended up working with the Other Ones Foundation. And through that work, she got connected to Integral Care. And so that's her first touch point with the behavioral health continuum of care. And so now I'm going to pass it off to Dr. Nuaid, who's going to talk about her first interaction.
Hello, I'm Ziad Nuaid. I'm a psychiatrist. I'm the chief medical officer for Integral Care. So this patient was referred to us for an intake assessment due to complications and contact precautions around COVID during that time. This was a telehealth assessment, and so there probably were some limitations in establishing rapport and gaining all the necessary information. During that assessment, the patient was diagnosed as having bipolar 2 disorder, a less severe form of bipolar disorder, and was referred for prescribing services with Integral Care, but declined at that time, perhaps due to feeling a rapport with her existing team at Community Care. And who knows, the limitations of the rapport that might have been, they tried to build over telehealth, but felt was not interested in taking medications for that concern at that time and not going somewhere else to receive services. Then I'll pass it on to Dr. Dubois.
Good evening. I'm Susan Dubois. I'm the Associate Chief Medical Officer at Community Care. Community Care does follow the primary care behavioral health model. That means when a patient comes in to see their family physician, they can often the same day see a behavioral health consultant, and they can get a referral to a psychiatrist who serves as a consultant, who helps with the diagnosis and treatment plan. At this time, in the current state, our organizations do not talk to one another with the electronic health record, and so the patient presented to Community Care to her family physician in July of 2021. At that time, she was working part-time, and she did have temporary housing. And with the primary care medical home, she was interested in starting medication. So she got a medication from the primary care physician. She was working with the counselor. She was referred to the psychiatrist who saw her. And after one appointment, did get a diagnosis of moderate major depressive disorder. And the medication was continued. In the time when she was housed, it was felt that her level of care was appropriate for Community Care, so no attempt was made to get her over to Integral Care at that time. Unfortunately, after several months of treatment, her housing disappeared, and she disappeared from us for about 2.5 years. She came in to see our convenient care location in 2024. It was noted that she reported impulsivity was affecting her work and her personal relationships, such that she was having difficulty staying employed. She declined medication despite referral to psychiatry again, and then had this dramatic presentation in July of 2025, where she came again to convenient care with right eyelid drooping, double vision, trouble swallowing, even difficulty raising her head. And at that time, she was sent to the emergency department to figure out what was going on. I'll pass it to Ashley.
So in July of 2025, because of these symptoms, she was actually medically hospitalized. At that time, she was diagnosed with myasthenia gravis, pretty severe, needed a pretty complicated medication regimen and even required infusions. At the time of her discharge from the hospital, she was still experiencing homelessness, but now she had the opportunity to continue to heal by going to Central Health's medical respite. So she ended up in our respite facility. While there, she did demonstrate some mental health symptoms close and to what Dr. Dubois said earlier, so that impulsivity was showing up and causing some interpersonal and altercations there as well. Because she had a good rapport with her medical respite team, they were able to talk with her more about seeking care with a psychiatric provider and a counselor. And because that was available, she did end up talking with the psychiatric provider and actually was open to taking psychiatric medications and is now doing that and doing a lot better actually in her care. In addition, she's also been weekly engaging with a counselor as well. While at medical respite, we talk about the complete healing and mental health, and it's not just about the medication portion, it's also about the social determinants of health that are affecting one's mental health. And so that was also addressed by her mental health team, by her medical respite team while she was there. So at this time, she's still there and doing better. I'm now going to pass it to Dr. Nuehid to talk a little bit more about psychiatric diagnosis and what that means in terms of severity.
So I think in many ways a case like this can be misleading because the patient seemed stable enough most of the time to participate in mental health services through primary care health. But it's clear that over a period of time that she was so chronically unwell that she was unhoused for long periods of time, not getting any kind of treatment at all, and was completely untreated and had exacerbation of her illness and potentially worsening of her physical health concerns due to that inability to access care. So there's clearly a portion of this where she moves into quadrant 2, which is firmly in the integral care space where her mental health needs are predominant, and we need to be able to connect her with care. At this point, I'll probably just pass it back to Dr. Trust to wrap this up.
Okay. So what we're trying to highlight is that mental health, it's a chronic disease, and it has periods that are remitting and relapsing. So one person can move along all of these quadrants, and it could even be exacerbated again with loss of housing or whatever stressors may be happening to an individual. And so while we talk about having, there's no wrong door, that is the right answer, but we also need to be thinking about, we need to have many doors, and there needs to be many settings, and there needs to be many opportunities to walk through those doors, because through any portion of that spectrum, through the remitting and relapsing, a person may have insight, right? That they may be trusting of their team. And at those points, we need to be able to get people engaged in care. And so we just wanted to highlight now what's happening in our current environment and what happens with the individual and how they move across all those spectrums of care, because it could be anyone. And I will pass it on to Dr. Lee.
So let's go to our next slide then. And we've been teeing this up a little bit. We're going to hear many voices in the next slide. So what does this slide represent? This is the same model you've seen. If you're paying close attention, these islands seem to have gotten bigger and they've gotten closer to each other. So that's intentional. You see, those like yin and yang models. That was the idea. You see a little bit of orange in the teal. You see dark, green in the teal. You see teal in the dark green, orange, dark green, et cetera, right? So the notion that rather than just personal cell phones of, colleagues and friends who make it happen around the margins, we are actually shoulder to shoulder. This is just, again, the notion of this rather than the physicality of it. We're shoulder to shoulder. We're not just cohabitating in the same space down the hall, but we are deeply integrated. That's the notion. And that there are these bidirectional bridges that make it easy to move back and forth. We don't have that 2.5-year gap where, this individual we heard about popped back on the radar. We were able to help her. We've got her more stable, but there were others who didn't make that journey, right? And so what I'd like to do is invite some of the voices who haven't spoken yet as much, maybe Dawn, Alan, John, and then open it up. team, let's talk about, what are the kind of opportunities for bridges, for integration that we see. And again, this is all now largely future state to the board, but some of the ideas we have viewed, there may be parts that are not future state that are current state we're exploring. So we'll just kind of give you all a flavor of that. I know there's a lot here, but we'll spend a little time on this slide. So Dawn, may I hand it over to you?
Sure. Thank you. Dawn Hanley. I'm the Chief Operations Officer and Vice President for Integral Care. Thank you for having us this evening. So you've heard a little bit about kind of what we're doing in our spaces and then the patient journey. And in this slide, I would have made those boxes a little bit bigger because I think we're doing a lot of work in that area now, more than we've ever done. And I'll just kind of give you an example of some of that work. Central Health helps the TDP, our diversion center. So where you look at that little navy blue box in the integral care area, in my mind, that serves multiple purposes. But if we're talking about an example of a program, their primary care team comes into our diversion center and provides medical care to the clients that are housed at TDP, at the diversion center. And we haven't had that integration at that level before, and it's their mobile team coming in, and I think that's a space that we can grow because we have several crisis residential programs that have that need and have high needs. We have like 5 total, and so that there's varying levels of care across the board there. Other work that we're doing together is in the inpatient space, which really isn't depicted in this island as much. It does fit in that left top quadrant. And we manage the contract through the pass-through for inpatient dollars to help get individuals that we're serving that inpatient care. But we also have an extended observation unit that takes in voluntary care as well, which Central Health helps support that work. And that's another space where we see those high comorbid conditions present, actually trimorbid with substance use, which really kind of plays across the whole continuum with this population. We are sitting on a healthcare collaborative, PSH healthcare collaborative together, planning on some of the things you heard in the example around individuals experiencing homelessness and how much more difficult it makes it to help engage and help keep them connected to care. When you don't have a safe and steady place to live, it makes it really difficult to concentrate on your care. So we have formed that collaborative together where we're going to be visiting some of these developments that are coming up that you see in the news around affordable housing. We have some housing we're bringing online. There are many providers here in the community that are bringing that housing online, but they don't have care in their space. So we have a mobile van. They've got mobile clinic as well, and so we're joining efforts there to kind of go and meet people where they are as we cross across these bridges. Another place where we've got strong support from Central Health is in our crisis services. So allowing us to go 24/7 at PES is really instrumental because that piece right there is serving as the front door, the triage to the deflection and diversion work that we're engaged in with the city and the county in Central Health. So that is critical because people don't have a crisis always from 8 to 5. So having that component and having those medical providers on site, and then the piece they added was we're able to take a higher level of care there. It's not quite inpatient, but it's observation bed. So normally, or in a large number of times, you can help people stabilize from their crisis within a 48-hour period. So having these 23-hour OBS gives us a better look. They may come in with other substances on board. So having some time to see kind of what's going on, it allows the providers to do a better assessment, one when they come in, one when we're moving them out of OBS, and then we can move them through that system of care into other residential if they don't need a higher level of care. So that support is invaluable as well. And then integrating the teams that we have with EMS, and I know Central Health supports EMS, so that's kind of a different, more indirect way, but we have that integrated first responder team, and then we just have another one that we roll out that we're going to focus on downtown that's going to serve some of these high acuity folks that are going to fit squarely in this top left box. So I think those are just some of the, off the top of my head, kind of items. I don't know if John has anything he wants to add that I missed.
Okay.
Or or Alan, Dr.
I'm going to
Schultz.
speak, otherwise I won't have a chance to speak. Alan Chelsea, Chief Medical Officer for Central Health, and thank you for the opportunity to really have this joint discussion. I wanted to reflect a little bit because I think sitting before you really sits at least a decade of us working together. I think we've gotten married, we've gotten divorced, we got married again. Normally, there was a time when Dawn and I purposefully would have sat at the opposite end of the table. It's different now. Never before. Well, I think one of the ways you could actually force collaboration is sit 9 people this closely to each other. So, great methodology. If we think about this model and we contrast it with another model that on the left side starts with collaboration and on the right side ends with true integration, right? In the past, we have co-located and barely collaborated, which means we've had 2 teams in the same environment, and Ashley and I could be working in the same place, but she could be facing that way, I could be facing the opposite way. Our electronic health records don't talk to each other, and basically it doesn't matter whether or not we were working in the same space. Versus some of the examples that Dawn shared where we actually have partial or true integration. We work as a team. We have access to each other's electronic health record. When there's a prescription change or a medical management change, the other team is there to support it and knows it. What happens and what affects mental health affects physical health and vice versa. So the model that you see before you consists of islands. Ultimately, even the borders of these islands need to disappear a little bit. And I think some of the examples Dawn gave are our attempts at moving that forward. I think M3 is another example, and the M3 is really a joint, medical and mental health team that cares for unhoused individuals with addiction disorders, mental health disorders, and at least 2 physical health disorders. So the sickest, really the sickest individuals that there are. And there's a lot of success there because of that collaboration. I think one of the questions that we've heard loudly and clearly from our board is, why do we all have some of each of these specialties? Why do we have behavioral health folks? Why do we have psychiatrists? And as you all know, the individuals that we jointly advocate for don't have the resources to, number one, navigate the system or even be transported from one care environment to the next. So anytime they touch the healthcare system, we need to be able to provide them the appropriate level of care, which means that our relationships, whether partner relationships or whether system partner relationships, we have to formally integrate because we may have moderate expertise within our environment to take care of the moderate severe patient, but Zaid was talking about severe mental illness. That is not our play area, right? So how do we ensure that when a patient is potentially being seen physically for us, and we are conducting a mental health intake, or at least assessing the patient based on mental health status, that Integral Care doesn't have to duplicate that intake, that potentially we can conduct the intake for both parties, and if we are not the appropriate partner organization, that patient smoothly flows across the bridge and is seen by an Integral Care provider, whether remotely or within our space. I'm going to stop there and hand it to Mr. Morgan.
I'll just highlight one additional area or two that are really the opportunities that we have over the course of the next 12 months and some of the work that was supported by the Central Health Board in our budget and the conversations that we've had jointly in the months leading up to that. We're looking at really a full assessment of our facilities across integral care, community care, central health, and to all the points that have been made, looking at what integration can and should look like across those service areas and across those facilities, looking at opportunities to co-locate, looking at opportunities to integrate, to embed teams, to embed intake specialists in both environments, in both directions. So that'll be part of our work for the upcoming year. We're going to continue to do some of the analysis that Jeff mentioned earlier around pharmacy and how can we optimize 340B and what are the real opportunities around pharmacy. And just this week, we kicked off a work group with some of the sheriff's staff at the county jail around opportunities around substance use treatment in the jail facility. That's for continuity for folks that come into the jail who are already on methadone or Suboxone, making sure that they're able to continue accessing their medications, looking at opportunities for introducing treatment and doing new inductions in the jail in alignment with the pilot that the jail has for long-acting injectables, and then navigation of folks as they're released from the jail back into outpatient treatment, whether that's at integral care, whether that's at community care or other community partners. So we're excited for all those areas of work in the next 12 months.
Thank you. So then maybe Nick or Susan, would you like to offer any comments here? Bridging the islands of care.
So we've initiated a monthly meeting between our behavioral health team and integral care. We sit at the same table and talk about complex cases and how those patients might move back and forth between the islands. And we also now have read-only access of each other's electronic health record. So if, we don't have to start over again. If we're thinking about diagnosis, we can see the patient's history in the other organization's space. And so these kind of collaborations are really exciting and moving us forward.
And Jeff, you want to take us home on this slide?
Yeah. Nick, anything you want to add? No.
I think you were going to lead with the
Okay.
pharmacy question.
Yeah, I mean, I think just to wrap this up and so we can all eat something, I really just want to emphasize that, I mean, you're hearing a lot of activity that's going on. Some of the things now that we all own that we have to do next is build the system approaches to this. There's been a lot of goodwill, even a lot of activity. Now we have to look at the ways to tie our systems more effectively together. John mentioned pharmacy being an important strategy to do that. We don't have to be on the same EHR to start sharing data, and we're starting to work out the ways to do that. Many of you know we have a regional health exchange here that's, I think, underutilized, and I think we want to be able to up the ante and use that much more as a tool to share this information. I think the last thing is we also have committed as a group to start meeting regularly to tackle some of the more complex issues. And I think, one of the things that Alan said too, which was, we need to kind of call each other on why we're doing certain things and be much more clear-throated about why and the most efficient way to do it, and hold each other more accountable for performance. And so that's where we're going to be starting to do the work next, which is a lot. We've talked about some of the kumbaya stuff and the easy wins. It's now getting a little stinky with each other once we've remarried and working this stuff out. But it's really tackling the systemic approaches to this, which I think is the work that you guys want to see us do. We can talk about all these things that we're doing. Now we need to build logic behind this and a model that we can sustain going forward. So I'll leave it there.
Yeah. And then just final comment here. This is difficult work. There's a lot here, and we know there's so much more to do. What gives us hope, I think, is the trust and the relationships that we are building. We have built. The remarriage is going well so far. Actually, the first version I heard was we got married, divorced, we got married second time, divorced a second time, and now we're dating again. So it looks like we're already making progress. And on top of the relationships, across the table, relationships between the boards, the governance, the aligned governance between the Integral Care Board, the Central Health Board, and the Community Care Board. We have an enormous privilege to have so many dedicated servant leaders in our community willing to give your time to help us steer into difficult space, but space that only gets better if we link arms, face the problem, put patients at the center always. So thank you for the opportunity tonight. Really appreciate it.
Thank you all. We're going to end with a trust exercise where I'm going to fall back and Pat will catch me. Are you ready for this? No, not yet. Too soon?
Yeah, really.
No EMS visits.
So, so thank you all very much. This is very, very, very interesting. A lot to think about. It is 6:29, and what we are going to try to do is take the next 15, 16 minutes or so, maybe a little bit longer, to ask our questions. And the purpose of this part is to make sure that we, all of us, ask questions of any of these folks to make sure we understand what they're telling us. And so that's what we're going to do during this time. Then we're going to break and get food, and then we'll come back and talk amongst the board. Our boards will talk and discuss some things around how we work together. So, but we want to, and I know that we could probably spend hours asking you guys questions. So, but let's keep it to our most important question right now. And I think what we can do is a round robin, and we'll just start. Do you want to start over there? Or?
Doesn't matter. Why don't you start with Shannon?
Okay, we're going to start with Shannon. And again, try to keep it to a minute or two if you can, maybe 3. So everybody gets the chance to ask your most burning question. And then that'll give us time to wrap up and still have time for a conversation. So.
I was like Jeff, I thought we were going to eat first.
Sorry, this is incentive for getting our questions asked quickly. Yeah. So.
Great point. First of all, thanks very much. This was very, very enlightening and very, very informative and very, very creative. I guess as one who's been here for quite some time and seen a lot of changes come about, what time frame can we think that what we're trying to do here can be inculcated within the system of care within our system? Because we've seen things come and go, come and go, come and go. And so we never get to a complete system. Now, I recognize there's no absolute complete system, but there has to be some time frame for a couple of reasons. One is taxpayers are expecting resources to be able to see outcomes. The second one is what's happening at the federal level is what's impacting all of us in health care. So I guess my question would be, and I don't mean each of you give me an answer, but maybe collectively or somehow you have thought this through, is within the next 5 years, 3 years, 2 years, whatever, do we see this system being able to be inculcated within our system seamlessly enough so that citizens who are partaking in the care that we're providing, we're seeing the outcomes that we're expecting, and that we don't have to depend on the sheriff to have to be the repository of all of those, but that we're able to help out in terms of providing the system. So I don't know if that can be answered in a quick 2 minutes.
Just give us a quick question, just give us a succinct answer, and we know that this is an area that really requires more discussion.
I mean, I think, Shannon, you're one of the things at the foundation of this, and I don't want to say this too glibly. I mean, the funding that we're struggling with right now is not going to get any better. So we truly do need to find ways to more work in a more coordinated fashion. And at the federal and at the state level, we're not seeing a commitment to support what we're trying to do here. So this has to be a very hyper-local strategy. And so I think there's very specific things that we have a strategic plan of Integral Care does that overlaps with the work that you all are talking about. Very specifically, we have some things we want to accomplish this year that Alan mentioned around building some of these connective tissue between our systems. I think one of the things we want to be able to say is rather than share anecdotes with you all, is start sharing data. And so our first step this year is to start building these systems to say, here's actually what's happening and here's how we're measuring that. I think if you want to give a timeline of whenever this is going to be finished, it won't be. But I think year over year, if we're committed to this, I see there's some small projects and small wins that we're working on now. There's some big projects that this community wants us to work arm in arm in, and Pat and I have spent a lot of time outside of this meeting to try and stand up. So yes, I think we're going to make commitments, but there's things we have to do foundationally and come back to you all with measuring this and showing you very specifically in concrete terms how we're moving that chain.
I agree with everything Jeff said. There's a lot of work happening already. The last year or two, much more than the past. We've got more on tap for this year. 34 million, Jeff, 33.4 million. Up from 28 million, up from 8 million. That's our commitment to integrated care last 3 years. So numbers of, dollars, of course, don't tell the whole story, but the intent and the direction. And I would say that in the next 5 years, in the next 3 to 5 years, if we continue down this path, a lot of substantive work should move. There is no end, as Jeff said, but I think the public should hold us to that. What can we get done in the next 3 to 5 years?
Thank you.
First, just want to commend y'all on a brilliant presentation, and I think not only were the quadrant diagrams very helpful, and as well as the patient vignette, but how you all depicted it, which maybe intentionally or unintentionally demonstrated fragmentation in some ways, and I think that was very, very clever. That said, this question I don't think is one that could be answered here, but I am interested in learning more, obviously as a layperson in this arena, around, my sense is that behavioral health conditions are the result of intrinsic and extrinsic variables. And, these extrinsic variables are community conditions that I might call them community conditions for the sake of this point, are what are uniquely interesting me, as I feel like our at-risk population might be growing, or high-risk population might be growing as a result of community conditions, sort of in a way that it hasn't been before. And I'm very interested to understand perhaps what projections look like there, and how we're envisioning sort of for lack of a better word, a pipeline of patients or seekers of care along the spectrum of acuity as a result of what seemed to me to be growing variables extrinsically that will be contributing to behavioral health conditions. And this is coming from, of course, years of working in the nonprofit health and human service world, where, of course, poverty is one of the key toxic stressors among so many other systemic biases, colorism and racism, and so many more are uniquely affecting populations, and I think at larger sort of orders of magnitude than before, as well as from my own personal experience being an individual who has the blessing of having advanced along this timeline and seen sort of from my relative point of view what seems to be a community conditions that are just fraught with toxic stressors. So very, very interested to know what the outlook might be in that, and to be educated about that as we move along.
Yeah, just a quick numbers. In terms of, we have a population in Travis County of about 1.35 million people. Approximately in 2024, there was about 300,000 people with a diagnosable mental health, behavioral health condition in this county. Of that, about 77,000 of those with a severe and persistent illness, meaning one that was ongoing and chronic. Nearly 15 to 20% of those are children. And that's holding for a constant state. I do think one of the things that that you brought up is that we need to we are in a bit of a trench in terms of support from the state and federal government around this, and the needs continue to grow. The acuity level and where we're treating people continues to be way too much in this state and in this county in our jail. We need to come up with more effective ways to treat people who need ongoing support in not just a ethical way, but with evidence-based that we know where people get better in. And we need to start building out that part of the system. But to your point, we are just growing as a community, even if everything stays constant, and we're not keeping up with the demand. I mean, you heard Nick talk about the community care, which is a huge FQHC, and we're one of the largest in the state of Texas LMHAs, and we're serving 35,000 people of that 300,000. So there is a huge gap in need that we need to address in this community, regardless of any environmental factor changing. But the trends towards in behavioral health, there used to be 1 in 5 Americans we've talked about in any given year having a treatable behavioral health condition. That's moving towards 1 in 4. Autism used to be 1 in 66. Now it's 1 in 31. We have a huge number of folks in our community that need our support.
Thank you. I know we're here for integral care and central health to have this discussion, but I'm curious, we're really here to discuss mental health with physical health, but in light of that, what role do you see the UT Medical School and the UT School of Social Work, should they not perhaps be at this table having this discussion with us, number one? And number two, plans for a true inpatient facility? Quick question.
Well, thanks for that softball. But yeah, I mean, no, actually, answer your question. We have been having conversations with UT around for a long time. We're actually meeting every couple of weeks now with them to talk specifically about the diversion center. And frankly, one of the things that, and I'll say this publicly, we have spent a lot of time with Andy Brown and the team around the diversion center to move towards looking at the diversion center as actually a psychiatric inpatient facility, and that we could create that entity. And UT will be a critical partner to make that happen. And we've been already in discussions with them and what role each of us could play in that model. And as a social worker, anytime we can get more social workers into the mix, and I'm not just saying it because Ann was a social worker.
If I could add to that, please, I think we look to partner with any, UT college where we can actually create some opportunities for workforce development. And we are contracting with UT for some of the subspecialties within, the psychiatric environment. And that is, I think one of the benefits of having, the med school, the residencies, work closely with us, because that wouldn't be something that we would have access to, a bipolar disorder, clinic, and they've got some other subspecialties that are pretty unique that we contract for.
Just to add to that too, we also work with UT through a residency program as well, and through the School of Social Work, through their advisory, the Integrated Behavioral Health Advisory Council. So Dr. Casey and myself sit on the board of that, and we're able to we've hired several APNs, social workers through that work, and also physicians. And so building that with them, I think that's just another place that UT is their work is embedded across the system.
And I just want to add, to look at the whole continuum here and the work that we've done together, education for getting people involved in wanting to do this work, and it comes from inspiring medical students and residents. And so there's been curriculum that's been laid out. It's in the integral care space, and I serve as faculty as well at UT to be teaching our residents, and so getting them involved in that, working with some of the mentors that's been in some of these spaces. I had mentioned Steve Shirkowski at some point, but we have great resources from UT that we've been utilizing, and as we build and also creating and emphasizing this exciting opportunity, so that we can keep the work going, because these are hard spaces, and so we need to think about the future, and that I think is with the education and excitement through UT and
Okay, we're going to move on now. Dr. Musaidov?
Thank you for the presentation. I'm really emotional right now. Just 20 minutes ago, talking about mental health and how it has impacted me. There's a ceasefire agreement, finally. The amount of mental and the pain that we all have been through the past 2 years, it's just, I cannot, so it's just irony. We're talking about mental health, and here we're all, and, sorry, I can't talk anymore. Thank you.
Oh, wait. I'll hold mine.
Well, I'm gonna do the same.
Okay.
Turn it. We just skipped over to your
No, I really don't have much in the way of questioning, because I understand exactly.
Sorry. My fault. Start over.
Okay. So I don't have much in the way of question. I see and understand a lot of where you're headed. The things that I think about, though, and it's probably, it could very well be early in this process of wondering a little bit about our youth and system penetration. While we have treatment services within the quadrants, most of these appear to be adult. When I begin to look at the penetration that we have, and I know, taking it to scale is going to mean justice systems, going to mean our JP courts, and how all of those particular pieces come together. And it would be real good, I think, to see some of those folks in the room and understanding the connections. As I looked at the test case that we just got, I wondered, just drop in that this person had was on probation for some reason, and the coordination of that. All of a sudden, not only is she on probation, but now she may even have a warrant out because she dropped out of sight for a period of time. So I know that it may not be where you are now, and I think about that and how all of those pieces as well will come together. So it's not necessarily a question, but I do want to get an understanding that it is something that you're projecting, or the vision as you talk about as we go forward.
Sarah?
Okay. Sarah?
All right, so thank you for this. So what I would like to do is just sort of clarify what I'm hearing and just make sure we're all kind of on the same page, because I feel like what you're talking about is really an unprecedented level of integration between two separate organizations. It's something that we really haven't been able to get to, I don't think, in our community. And so I think with that is going to come a lot of infrastructure, right? So, in my mind, I'm thinking, okay, patient level tracking, care coordination, this is infrastructure that, integral care, the way that we're funded, it's really hard for us. We run call centers, we do the 988, but those folks are not necessarily, and they handle referrals, and I'm sure, Dawn can tell us all of the things that they do. But I do think that this is going to take a really elevated level of patient level, not only tracking, but also population goals, right? So not only do we need to track these folks and be able to coordinate their care, but we also need to set some goals around that and see how we're actually performing. But anyways, can you just sort of speak to the level of integration? Because when we start talking about integrating to the point where we can leverage 340B, being a healthcare attorney, I know what kind of, integration that's going to take. And so can you just kind of give me your quick vision of what that could look like for these?
Another softball question. I'll go first, but others please jump in. I wanted to acknowledge that I think you are seeing the direction we're heading in correctly, and the scope of the challenge and the depth of integration that is required, and calling out that, as you said at the beginning, we've only put 3 islands of care on this page, not because there aren't other islands, not because the justice system, the forensic system, right, police, EMS, UT, Sobering Center, many, many others, right? There are many islands of care. This is just meant to kind of get the idea of the model, and that if we can figure out at least these 3 islands of care, that might be a place with which to build out, which has to be done. And it will take investment of time, effort, systems, and resources. And what happens if we don't do that? Right? So this is not a space where the problems magically disappear. They may well be getting worse. And who has to pay that cost? Our understanding is that the public pays the cost. The taxpayers pay the cost. If these issues are not cared for, someone gets sicker, needs more expensive care in a more expensive setting. They may end up on the street. They may end up involved with justice. They may end up in the jail. They may end up in combat to stand trial in a isolation center where most of the mental health care right now is occurring. And we know that's not right. And we also know that is not good stewardship of taxpayer dollars. We can spend those dollars much more effectively in treatment upstream. And it's not just taxpayers in our community. We have a business environment that is impacted by this. What happens every day on Congress Avenue affects all of us. There are opportunities for others potentially to see the work that we are doing, kick the tires, challenge us, and then maybe add some fuel to the tank, because there are different funding sources beyond the taxpayers that really could consider contributing to this. I do think this particular set of relationships may be unprecedented for our community and is not that common around the country. This is an awesome opportunity for us to do what we do best in this blueberry and the tomato soup, which is to build things that break the mold, do what's right, think bold, and what starts here can change the world. So there is that opportunity here, and we know we can't do this alone.
But getting back to the meat and potato of your question, sorry, I keep thinking about food when I stare at those sandwiches. But I do think,
Any minute now, Jeff, any minute.
I know it's a subliminal suggestion, Ann.
Yes,
But-
that's right.
But I really, I think we're going to have to take some of these issues that you just described, and they will explode those issues. We need to look at a population-specific approach. But I think around the other thing you just described, if we have to look at how we're going to do it. But if we're able to provide access, pharmacy access, that drives a lot of other of these initiatives at the same time. And that's why we're going to look at ones that create wins, but also open up other ways of integration around data and information exchange. So that's part of the reason why we're looking at those.
Can I add just one point to that?
Ed?
Co-credentialing.
Yeah.
That's
Oh,
one
yeah.
step we've
Yeah.
taken.
Yeah.
Okay. Ed?
I'm excited about what you were presenting. Deja vu for me. Back in the 70s, we were talking about something similar and was working with local providers in order to have mental health and physical health working together on behalf of the patient. This is exciting. But my question is, what is the commitment to keep this model going forth, even if the current personalities change?
I'm honestly, this is what I'm going to throw back at these boards, which is, as this is one that the reason we're having this discussion, and I mean this absolutely with due respect. I mean, Pat and I and our teams are doing this, and we're committed to this. But if we leave, retire, whatever we end up doing, part of the focus is how do we keep this going, and that's why this board connection is so critical.
I think that's one of the questions we should be talking about in the second half of our discussion. That's a good question to raise. Yeah.
Okay, so thank you for considering the criminal justice system as an island. I would probably call it the moat or the in-between. And so each time I see the models where the islands are coming together, it does something for me, because the more that you all work together, the less opportunity they come to see us, right? And so I think that's really important. You said, what happens if we don't get better? it's going to continue. 40% of the population are going to be in our care. And you've been talking about how when they have mental illness, they also have physical health that's poor. And we not only see them physically sick and mentally sick, but we see them die because of those two things. And so I could go on a list of what would happen if y'all don't get better, or we don't all get better, right? We live in a state that it's divide and conquer when it comes to funding. So what are you doing to, working together, that's great, and we need to do that, but we've got to be able to take the resources and beat the Capitol. I don't know. I could go on and on about that, and I don't want to, but we've got to get the funding together, because it's all limited. We went to Lubbock and we saw where they get funding, but Travis County didn't get funding. So coming together, it's harder to conquer, right? So thank you. I appreciate this more than anybody knows.
But one of the things that we have is in this community is we have central health, which other communities don't have. And I really mean that as coming from the Northeast where Medicaid was very robust, we were able to do some really good things, but we always failed when we talked about integration with medical and behavioral health. Those lanes even widened. I think we have an opportunity here because of this community to do those things you described. Perfection is an aspiration and shouldn't stop us from chipping away at this. But I agree, our choice is not to not do this.
And, I would add, and think that moat is a beautiful addition to our metaphor. So, Sheriff, we may steal that.
They're falling in.
Thank you for the kind words, Jeff. We have Central Health, but Central Health exists in Travis County. Right? When we ask people in Travis County, do you believe people should be healthy? Do you believe health is a human right? 94% of people in Travis County say yes. I grew up in the Bay Area in California, worked in Boston for 17 years. I was in Brooklyn for 3 years. I'm not sure that it's 94% in any of those bastions of liberal democracy, right? We are very blue in terms of our belief in health as a human right. We also want to see money spent well, right? We may be socially progressive but fiscally conservative. Don't waste my money, right? So that both of those pressures combined, I think, make Travis County one of the very best places that I can think of to do this work. Yes, we need to figure out how to do this. No one's going to come and save us. We're the ones we've been waiting for. We're going to be hyper-local and do this together. Yeah.
So I'm going to close this out at this point, and then we'll have food. I just want to say three things. This is not a question. It doesn't require any response. It's just I'd like to ask you guys to think about two additional things that you probably already have, but I didn't see them in the list of 10. One of them is community. How does the community, and I think Amit brought this up too, but how do we think about where the community fits in this model? So that's one question. Second one is care coordination, or case management, whatever term you want to use. How does that fit in terms of connecting people across the islands? So two things. Then the last thing is, maybe this is the attorney in me or something else. I would love to see a list of the challenges that you all are going to work your way through. Because as a board member, that helps me go, okay, they're going to work through this, and then they're going to come back and talk to us about it. So, okay, why don't we get food now? Let's be, get food, bring it back here, and then we're going to turn this over to Pam, who's going to lead us through the last part. You want to say anything?
No, Ann took my line. I want to know what your obstacles are.
Yes.
I want to know what your obstacles are so that we can figure out how we help knock them down.
Yeah. Okay, so let's, I think the food's right over here. Go grab your food and Discuss, identify, and take appropriate action on how the Central Health and Integral Care Boards will implement strategies, principles, and processes to collaborate on the delivery of mental health services for low-income and uninsured people in Travis County. Okay, so guys, this is the discussion portion where we have the opportunity to talk with each other. And we're going to turn this over to Pam. Pam, are you comfortable there, or do you want to sit somewhere else, or do you want to
sit just because I'm moving with the speaker?
Okay.
We just talked about it with the microphone. I'm good.
Okay.
And that part that you just said, because I think there was a lot going on, do you mind resetting with that?
Rereading? Okay. Okay, guys, if we could, if we could sit down
I
and.
don't want to miss the opportunity.
Okay. All right, so I'm going to read this again. We're going to talk today, we're going to discuss and identify how the Central Health and Integral Care Boards will implement strategies, principles, and processes to collaborate on the delivery of mental health services for low-income and uninsured people in Travis County.
Great. All right.
And Pam is going to lead us through this conversation.
Awesome. Okay, so a lot was said during the presentation about the new model, and you've already had a chance to ask some questions. It really led to some general perspective around what was resonating with you, and maybe some pointing out of what attention around what the obstacles might be. And so I don't want to underestimate the fact that what they are proposing to lift is huge, multifaceted, complex, a lot of moving parts, the pieces around the funding, how the organizations will do that work. And so part of that piece is to have a discussion or initiate a discussion that I can assure you will not wrap in a nice, neat little bow in this one meeting, but around how then you as the two different boards that represent the two organizations will then come together and be a part of this work and help kind of co-create this work alongside the staff, and also what that looks and sounds like as they enter into this exciting time. And so the first question that I want to explore with you as we think about the word collaboration, which was named 29 times during the first part, because I did informal, I like data, informal data, so 29 times the word collaboration was named. And in the spirit of that, there is a lot that goes into that word. And so there are whole frameworks and network mindsets around what collaboration is and is not. And there are key performance indicators of that. There are behaviors associated with that. There are sustainability measures put in place that create the churn for collaboration to occur. So in that frame and realm, as we talk about this, I want you to keep collaboration as kind of the backdrop as we explore some of these things. A lot of times collaboration sounds amazing and fun, but what's not talked about are those spaces where you have to have really courageous conversations about what you are not going to be in order to be collaborative. And so as a guide at Austin Together who, walks organizations through collaboration, I've just finished one on maternal health in the last couple years. There is the idea of collaboration, and then there is the operationalizing of collaboration. And that's when the plan that was put in front of you starts to take hold and be functional. So I'd like to explore with you the ideas around what are your thoughts around parameters or limitations or boundaries or even opportunities that both of you as the boards should establish around this plan in terms of service expansion to really prevent or start the pathway of giving attention to the duplication of existing services delivery. So big question, but as you listen to what they presented, we are on the islands. We have understood kind of what those look like. We've added a moat to that, or I think that was brilliant, to that visual depiction. What is coming up for you as you sit in your board seat around parameters, limitations, boundaries, things that you want to bring forward proactively in this discussion as we start to have more discussions as it relates to service expansion, alignment, service delivery, duplication? Does anybody want to? Trish?
I'll go. You all have food in your mouth. I just have it in my
Perfect
hands.
timing.
Just have it in my hands. I think a principle that I feel like would be useful from the standpoint of being a board member, and as both organizations have to make decisions going forward about how we fill out this continuum, how we build the bridges, how things work, how we integrate, is can we say in every decision that we're making, we are putting the patient front and center? And I mean that not just to give lip service to it, but to say, how does this affect the patient if we do it this way versus how does it affect the patient if we do it that way? It's so easy because of all the pressures we're under, the regulatory parameters, the funding parameters, the policy parameters, that we tend to become provider-centric, right? Because that almost becomes it's like the place of least resistance. And that turns us into a kind of a supply-driven organization as opposed to a demand-driven organization. But I feel like if we keep the patient, if we ask that question in every action we're trying to take, it helps us at least. If we have to make a different decision, we know that we're making it consciously. This is not in the best, and this is not how we would love for the system to work, but it's got to under the current circumstances. But I want us to have gone through consciously that process.
Perfect. So in the world of forming collaboration, the way in which we then back into that question to test it, or that concept, is to be able to say, do we believe that centering the patient, right, or centering the patient is a core principle or core value? So that's how you can test as we go into this work around if we are sitting in a situation where there are two different organizations with two different organizational cultures, two boards with two different board cultures and principles and core values that might need a discussion around to make sure we're on the same page. The way to do that framing is to test it by saying, do we believe that patient-centered care is a core value or principle as we enter into this work? Okay, anybody else? Do I need to reframe? Yes.
I would say that I'm not quite sure how to articulate it, but the process for decision-making needs to be collaborative. And from a board perspective, we need to understand our role in the decision-making and, where is that? Budgetary is one of our roles, how things are paid for. There are strategy is one of our roles. But we need to be clear, or from my perspective, I think it's important that we have a collaborative decision-making. So if we as entities are really going to work together in that way, we need to be both, we need to be respectful of each other's perspectives, each other's needs, and we need to have those discussions as part of decision-making. And the board has a role in decision-making. So we need to think about where and when the discussions happen at the board in terms of things like, I don't know, I'm trying to think of an example. If we've identified a gap in care, the thinking around how to fill that gap, who fills that gap, how we pay for that gap, at some point that comes to our board. So we need to make sure we're all understanding what the process is. So I think that's a component.
So the framework would be something like, what would be the protocol for decision-making that is collaborative as it relates to this project and work? Okay? Shannon, were you going to say something? You moved. You're up.
I think that one of the things we have to get to the agreement is that the board cannot always be engaged in all of the nuances that go into what ultimately would be the decision making. The board should be the final arbiter, but we need systems by which individuals within each organizations are routinely meeting, dialoguing, interacting, providing patient input, getting patient input, family and community to help foster that, so that by the time we have a recommendation to a board, we have something that is complete or as comprehensive as possible. I think a lot of time bureaucracies have a tendency to say, this is what we think, this is what they think, this is what they think, and then they push them together and come up with something that is a hodgepodge, but is not necessarily a synergistic understanding of what the community and what the patients need. I don't know if that makes sense, but I think that I just think we need to start sort of at a lower level and have a working group of practitioners, providers, staff, and others that are helping to do what we're asking the board to finally decide on.
Okay, so I want to just mirror back to you and correct me where you need, where I have missed it. So what I heard you say was there's got to be some kind of agreement protocol for the board, the collective boards around, not getting down in the nuances of all the pieces as it relates to the strategy and all those wires, and kind of some norms around, the communication process and doing that, but also when it comes to the board, it's at a certain level of comprehensive framework so that the board is then in a position to either approve and or not approve, or at what level do you want the engagement to be?
I think it needs to start at the staff level with community. Now, that doesn't mean board members cannot participate in that, but I think that needs to start because it's my experience that staff and community know more about how the types of systems that will work best for them. And then ultimately it finds its way up through the processes to the various boards. And then the boards need to meet on a routine basis to decide this is what we've come up with, this is what we've agreed to from our various components, and then make some decisions, policy decisions or operational decisions or whatever, financial decisions.
Okay, so I think there's some opportunity to get clarity around roles and responsibilities in this iteration of the project, that we would be centering the expertise of staff to really lead those pieces, and then the board to have a cadence of communication and meeting in order to understand those pieces and be able to advise thoughtfully.
Yes.
Okay.
I would add one other piece that I think I heard Shannon saying, and that's community. And I don't want to put words in your mouth, but that kind of triggered for me thinking that in terms of the barriers to a system of care that's focused on patients, we also need to talk to patients or people in the community that can help us identify and understand that. And so some sort of process for doing so, I think would be useful.
I thought I said community, but
yeah.
I think there needs to be an ongoing process by which that can happen.
Yeah. I mean, the framework around, if you want the problem solved, you ask the people who are in the community that have the problem as an extension of staff.
Yeah.
Probably is in a unique position with many of the clients that we see and interact with to provide her staff to provide the type of support that is needed from community.
Absolutely. Anybody else weighing in on those pieces?
I think it's very important that each board has a clear understanding of our roles and responsibilities. The Central Health Board holds
all the fiduciary responsibility. And we have to have, for example, that's just one example that's clearly understood that that proposals proposed are not turned down per se out of malignancy or whatever, but the reality of a budget we may be facing. And I think that to have those roles very clearly defined, what Integral Care's roles are and responsibilities and ours are, is a very important starting point to understanding each other. And for better trust in each other, really.
I was just going to add to what you said. Not only do we understand each other's roles, not only do we need to understand each other's roles and responsibilities, but and where you mentioned that we all come back together, but in between that the message that is being brought to the boards are consistent to both boards, right?
Yeah. And I would add that there's roles and responsibilities vis-a-vis each other, but there's also roles and responsibilities vis-a-vis the community, and challenges. I don't know. I think it's important that we understand that part of our relationship between Central Health and Integral Care is fiduciary, as you mentioned, but we also need to understand on the Central Health side that Integral Care is an LMHA, which means that they're established by state law and responsible for setting community planning, community-wide planning for Integral Care. So, I mean, for mental health services, and I may not be saying that exactly right, but there's statutory requirements for. So we've got a situation where we have a government entity that's charged with planning for mental health services in our community. That is not a taxing entity because our state has not done that. So they're charged with responsibilities without being funded specifically for those responsibilities. So that all I'm trying to say is I think that our relationship, the Central Health and Integral Care relationships are pretty complicated. It's much more than just we're funding, Central Health is funding Integral Care.
Right.
I mean, I'm not saying that that's all you meant. I'm just broadening what you
And that's
said.
my point. It's a very complicated relationship, and
Yes.
it should be delineated.
Right.
So everyone understands that
Exactly.
more clearly.
I think that's a really good point. Yeah.
Okay,
Were you gonna say
others? Think about the parameters, the limitations, the opportunities, boundaries, obstacles as it relates to the service expansion and lifting this work.
I agree with everything that's been said around the community to staff-based approach in as much as recommendations to the boards, human patient-centered approach that's demand-driven, paradigm for, I think, decision-making is going to be extremely important. And this notion that Dr. Martin mentioned, particularly around understanding our purviews in a world where our purviews cross over quite a bit in as much as the grander goal of our respective missions. And we're all in environments where the resources are finite and the needs easily eclipse the resources. And sort of coming back to a paradigm for decision-making, one that perhaps honors the distinctions in our missions, the overlaps in our missions, and helps guide what controls whenever resources might come into conflict. I think that would be helpful. But the thing that came to mind to maybe add to the salient notions that have already been brought up is just bread and butter goal-based governance. So what grand goal do we intend to move? What indicator needle do we want to move? And what are the milestones to get there, and how are we measuring that? Everything can't be measured in bread and butter little nuggets, but some things can, and so we should be doing that.
Okay. Other feedback?
I'd like, oh, well, you're good. I would just like to piggyback off of what my colleague said, is that in that measurement, I think it goes back to the question of the community. That input needs to come in from the community to make sure that the outcomes that we're deriving are not just epidemiological or political outcomes, but actual community-based, citizens approved and comfortable models, I guess is what I'm saying. And we need to keep emphasizing that because we have a tendency, we politicians and bureaucrats have a tendency to put everything in those terms and not always take in the community aspects of it. So.
Exactly where I was going to go, and that if patient-centered care is our value, there are many collaboration tentacles in the community that contributes to decision-making that goes from the bottom upwardly. So we need to keep in mind that those community tentacles are value and have a lot to offer in whatever the final outcome is for a patient-centered care model.
Okay. I want to hang on that for a minute. So I've heard that now a couple of times. I want you to just go another step and explore some examples of what you mean when you say that the community is a direct line to this piece around patient-centered care. So if I said to you, give me an example of what that would look and sound like as it relates to this visual. Of course, he's smiling because he knew I was going here. I know you're like, I knew she was going to go there. I am. Give me an example. Let's not talk hypothetically. If we walked out today and this was on the news and the question was, we are going to be doing patient-centered care by way of making sure that we do not forget and or we center the community. Give me an example of what that might look or sound like.
After you.
My example would be from a personal contact from community persons who are in need of care. That comes to me as a pastor and is in crisis, then I will have to navigate from that perspective to try to get that person within the system of care that exists without going through a whole lot of barriers.
Okay.
Because I go to here, now we can't see that person because of this. Go here, I can't see that person because of that. But if we're talking about linking these islands together, that would certainly be an easier communication to persons like myself who said this exists within the community and this is how you navigate that.
So you're saying a high-touch approach and a connected approach where you are really able to meet person to person, but then there are reduced barriers or reduced obstacles to move about the islands efficiently to
Right.
get to match the care.
Right.
Okay. Yes.
I think it looks like advisory councils, whether they're patient advisory councils or broader community advisory councils, patient advisory council I think is pretty straightforward in as much as what it could comprise. I don't want to flesh it out because I don't know that I would do full justice without really thinking it through comprehensively. I think beyond that, though, in as much as community advisory councils could be concerned, there are not only community members, obviously directly, irrespective of their profession, who I think we should actively and consciously seek out, but also many professionals in the space and not in the space whom we could also seek out, whether it's parent support specialists in the public schools, social workers who are in private nonprofits or in public human service environments, folks who are on the pulse as well and can serve uniquely as a bridge between, for lack of a better word, on the ground community needs and professional jargon, and sort of these echo chambers that Shannon was referencing, that we can get caught in our jargon and our way of saying and doing things, but I do think soliciting that feedback by means of an organized process is helpful, and I do also appreciate the notion that these are public boards where community comment is facilitated.
Okay, thank you for a couple of examples. Other parameters, yes.
I want to, do you want to go first? No, you can go ahead. I want to circle back to something that we've kind of started to talk about, but just identify it a little bit clearer, I think, is, I think one of the, because we're talking about decision-making and parameters for how we move forward. One of the things that's important to recognize is the funding challenges. And I think someone may have mentioned it earlier, but from a Central Health perspective, which is a taxing entity, we have funding challenges also. And so Central Health has to think in terms of what can be funded within the dollars that Central Health has. And Central Health also has responsibilities for the care of patients. And we've talked about how you can't separate mind and body. So it's the decision-making around how the taxpayers' resources are used and how they're used for physical health and for mental health is a tough question. And we're sitting in an environment where it's difficult to identify the sources of funding that are specifically for mental health services because of the challenges that we have and the cuts that we're seeing. So I'm just identifying that as a challenge, and the decision making, the parameters or criteria for how those decisions are made. I don't know that I can identify them all. I'm just saying that it's an issue because I think we all share the vision of patient-centered care, and we all recognize that mind and body is important, so physical health and mental health services are important, but then we also all acknowledge that resources are finite. So how we make decisions across our bodies in a way that's collaborative is going to be interesting. It's going to be challenging. So I just want to put a marker there. I don't have an answer for it. I just want to put a marker there, and I think that thinking through a way that we can do that in a collaborative fashion would be ideal.
So I appreciate you putting that marker there. And as we get ready, and I want you to give me your comment, but as you're giving me your comment, I want y'all to also start thinking about what do you think will be the easiest conversations to have collectively as a board, as a collective, two boards together, and what do you think are the top, more challenging conversations, with funding being the top probably.
Yeah, that's the most challenging.
And so I want you to think in that framework in this next piece. And yes, I'm ready for your comment.
Go ahead.
Thank you. Everything has been presented great, but I also believe we cannot achieve this work if we are not taking care of our staff. And I think you outlined here having equity-focused workforce. So we need that workforce in order to implement the work that we're all talking about here. We have heard from several of your staff members who came before us and talked about some of the financial challenges they also do have. If they're not able to keep up with their day-to-day finances, how are they going to take care of our patients, our community? So when we're thinking about addressing this matter, we also need to focus on the people that are delivering the care. And that goes both ways with central health and integral care. So I would hope that that would be one of the core fundamentals as we're discussing the great system that we want to plan and design before us, that we're really taking care of the people. So that's really one of my comments.
Okay. Did I hear you in the beginning of that talk say equity-focused care? Did I hear that?
Well, I
that your-
see here an outline of equity-focused workforce, but it's 0% as well here. And that should not be 0. It should be 100% and more, because if we're not taking care of the people who are delivering the care, how are they going to deliver the care?
Got it.
So especially for this vulnerable population. So if an individual is suffering their own mental health, how can they deliver that behavioral health for another person? How can they tell them about optimism and hope while they don't see it themselves? So I think we need to really focus on that aspect as we are developing and moving forward.
Thank you so much. So as you're going to be responding to the easiest and probably the most challenging or difficult conversations to be had as collective teammates in this type of process, I want to just give you the framework of what that means when we say a collaborative mindset, because we've talked principle, we've talked core value, we've talked a little bit about what we want to center in the work. And so there are some pieces that I want you to think about that informs your answer around the easiest and potentially most difficult conversations. The first piece around the collaborative framework is that it prioritizes collective success. It is open to sharing resources, centers building strong relationships, and leverages interconnectedness for greater outcomes than working separately. Translation, that overall the goal becomes to create a successful ecosystem, AKA island. Now, with that said, because it's not just the tactics of it, it is the mindset of it, right? So the mindset of it lends itself to a way of thinking that prioritizes collective goals and outcomes over individual organizational gains. Okay? So then the part that always gets left off when they train you in collaboration is that nobody says up front that there will be something that you will have to give up. Now, with that said, what do you think will be the easiest conversations for you to have? And what do you think, with I think funding being put up as the first, will be the challenging and most difficult conversations to have among you? Let's start with easiest, unless you've had your cookie, and then we can start with hard. If you haven't eaten the dessert, let's start with easy.
There are cookies.
Easiest conversation. Are there cookies? There's no cookie? Who did? Who made? I'm just kidding. Always have a cookie when you're doing this kind of work. Okay. Sorry. What do you think are the easiest conversations? You're like, oh, I just watched them present this. These are the easy pieces. Trish?
Needs. The easy pieces are identifying what's wrong, what's not working, what's failing.
Okay. Needs, gaps.
I doubt that we will disagree on those things.
Okay. So the what feels pretty easy.
Yeah.
Anybody else? What's the easy conversation?
Well, I don't anticipate any difficult ones because I think the vision and the mission is in alignment because both entities are really committed to serving this vulnerable population. I don't foresee an issue personally on that aspect. So unless someone disagrees, I think we're all in alignment with that. So I think the most it will, unless someone disagrees, that there will be any. I personally, based on the conversations that I've had, but I can see some difficult and challenging ones, whenever that is ready that we can discuss. But yeah, I think both groups, and we saw the love connection between Dr. Lee and Jeff there. So the trust aspect, so that's really common.
Okay. I love that. I love that perspective. Going into the 31st year of doing this, we've never not had a hardest list in any collaboration I've done. But if it happens here, I'll retire. I'll retire. I will be thrilled if that happens. But the hardest ones aren't something that's negative. Hard means you are willing to roll in the deep to get it right. So it's not necessarily, hard is not necessarily a negative. It is the opportunity to identify it and then commit to leaning into figuring out how to reset it in a way that is mutually aligned and beneficial. So not necessarily a negative. Yes.
Wait, did you have something about?
We're on easy. Keeping you there.
I think the easy things can come from shared values and clear facts. And I think some of these lack of better metaphor, low-hanging fruit options, maybe either conditions or types of conditions or whose treatment, conditions where one condition perhaps in the behavioral health arena might have a causal relationship with another condition in the medical health arena, or one condition that's within the purview of one of the organization's mission has a causal relationship with another, and therefore there's a 1 + 1 = 3 effect, and sort of approaching them together, very easy, clear ROI. I think those are kind of the easy things. Defining what those are, would leave that to the experts. You could probably rail off a few of them. But yeah, really keen to get into the difficulty part.
Oh, I know.
We can all think of difficult.
Oh, I see it. I can feel it. Any other
I
easy?
just want to ask, now we're talking at the board.
Yes,
So,
correct.
Those sometimes appear to be.
Emmett, Mike.
No worries, right? Okay. So those board level decisions often, I think, are going to be based on the information that we receive. And we're going to get that information from, we're talking about the different islands or even the different doors. So we're really having to filter through. Now, the hope is that we're filtering through information that's going to be valuable to us in making decisions. So if we're not getting all of the information at this board level, then some of our decisions will naturally be faulty, because we don't know. We don't get necessarily into the weeds of operations or in particular problems that clients and families may be facing.
Right.
So we have to have that advocacy, and I heard a little bit about advisory groups and things like that, but for me, that's the information, and I may have gone into hard, I don't know.
Nope.
But that's the thing that's important to me. Easy stuff is easy stuff.
So basically, it's easy.
Somebody else can do it.
Right.
So for us at the board level, I'm looking for more complex things, and sometimes that means generating information from different sources, and sometimes we don't get that information.
Yeah.
And there is the problem that I'm challenged with. It may even be filtered.
Got it.
Yeah.
So what I heard was it will be easy if the data that you are given, right, is forthcoming, complete, accurate, and it will lend itself to a good decision. So
it's
your
coming
decisions
from
are only as
sources.
good as your data that you
And
receive.
the sources of that data.
Got
It may not necessarily be data, it's just information.
Okay.
And I would add, someone had said earlier, the same information to all of us.
Okay. All right, anything else that's easy?
Well, I think I also heard you say that we deal with the hard stuff.
Well, yeah, you know, 'cause,
Yeah, because that's the complex.
yeah.
Okay,
So if y'all done with easy,
so I heard,
Can I just add?
Uh-huh.
Information that we need to know, not that you think we want to, right?
Yeah,
It's got to be information we need to know, not what you necessarily want us to know.
yes, thank you.
don't tell me what I want to hear.
That's right.
Yeah.
I don't know that I said that right, but you
Yeah,
know what I mean.
I got you. And I think that's going to be any challenge, and when we're building these sorts of collaborations, you know. And you mentioned training on collaborations, you know, and I think that's critical. You're going to be operating at different levels, and sometimes people just don't like each other, you know, or sometimes people have different issues and concerns. They may not have a relationship like Jeff and Pat, which is admirable. Great modeling for that. You know, important. That's
Absolutely.
important, I think. But where do we get a sense of our staff is fully engaged in understanding what this collaboration means? Are we communicating?
Right.
Are we getting all of the I guess all of the C's: cooperation, collaboration, communication, building us into a knowledgeable system. We're just not getting filtered stuff.
right. So part of this, the answer is it's all new. So whatever norms you had previously in this iteration of boards separately in two different organizations, those norms are not established yet. So when you talk about how much information, how it's given, where it's given, all of those things will have to be a commitment to establish that it's all new in those spaces. And then how do you toggle between the newness of this collaboration and the rules of engagement in your own separate organizations? Totally different, right, hat. So part of that is you have to establish it and be willing to sit in a space to establish the new, to do the work, to align with the plan they're bringing forward. Okay, let's move to hardest, perceived hardest, potentially hard.
So, being on this board for a while, funding is an issue. We only have one stream of funding. We also have responsibilities. We have commitments. We are an enterprise. We have Sendera health plans, we have community care, and Central Health, which we also launched specialty services. So we want primarily to ensure that we're sustaining those services, but sometimes, given some of the recent conversations we've had, we had to somewhat compromise which service. Like for instance, this budget season, the idea was about stabilizing and optimizing the services because of the funding streams that we had, and also in the previous years we did not dedicate the significant amount to integral care, so it had some financial implications on the current services we have. So I think some of the difficult conversations: what are we gonna compromise? What is our priorities? And how much could we invest, and to what extent, and what are those services that we as Central Health see as a primary need for our patients, whereas that we can collaborate on those issues. Obviously, the great vision that we collaborate on all. I don't foresee it's feasible to collaborate on every single aspect that all the services that Integral Care provides. So that's what I foresee, some of the challenging conversations. We actually had previous conversations along the board, along to what primarily to some of the funding and sustainability of the funding to Integral Care for how long. So we've already had some of these conversations, and I foresee them to continue.
Great. Can you hold it, because I don't want to miss this. Let me just ask one more question. So can you talk a little bit more about why you would not be able to collaborate on all services?
So if it had a fiscal
a number attached to it, it might be difficult. But in terms of expertise and skills, I see everyone collaborating. But given how Central Health is the business model right now and only one funding stream and the services and the expansion of care, so that's why I force. It's not that we do not want, but there are certain limitations to what possibly could happen. So that is why I think the
Spot on.
yeah.
Yes.
Could I elaborate?
Yes.
I think the challenge is deciding if we are patient-centered, I'm just going to say the ideal, which obviously we can't do, but if we're patient-centered, if the patient falls in our scope because they're uninsured or low-insured, theoretically, we should be providing everything that patient needs, whether it's mental health care or it's behavioral health care, mental health care, or physical health care. So that butts up against the realities that ROM is identified in terms of the dollars. So that's just another aspect of the challenges, So, it goes back to, theoretically, if you're insuring a patient, you pay a premium and they get covered for a scope of services. We're not exactly set up that way. We do have MAP, so what does MAP cover in terms of mental health services? So these are all the kinds of questions that we need to think about. So I'm thinking about from that perspective, at what point are we saying, well, we can't cover that service or we can't cover that patient? So the other thing I want to talk about too that's related to the funding is to what extent, and this is hard, is like to what extent can we be helpful, can we be a partner in broadening the pie of dollars? So that's another thing for us to think about, whether that's our tax dollars or whether that's some other source of funding. What's our role in helping with that? And that's a hard one. What's our role, Central Health? What's our role, Integral Care?
Absolutely. And in order to shore that up, then the conversation around how you define everything for a patient, right, becomes part of that. So you heard, and I can't remember, was it Dawn, that said, we are at a point where we have observation beds, but not complete inpatient care, but closer than none. So then you have to then, in this new norm, decide what's everything, what's enough, what does that look like in terms of delivery, can you afford it? Right? All pieces of it. Other things that would be considered hard.
Shannon, were you going to go?
You're first.
Okay. I'm a physician, so I think kind of concretely, and like an attorney, I want to list. I think a difficulty that we really need to address, that we find difficult, is to set goals for the year. Not some theoretical that we boards tend to do, discuss theoreticals. To agree on a plan for the year, a checklist for the year, a checklist for 2 years, 3 years, 5 years, in coordination with Jeff and Pat. So we're more high level a discussion about that and have them kind of put it into motion. And I think that could be an issue of difficulty. So what we each prioritize, each board, and I think it could be a difficult area of discussion. But I think to have that, rather than just diddle-daddle forever, but to sort of, we're doing this, we're in agreement, we're going to move forward with this.
Right. There's a whole protocol that happens then if you get to the goals, and if this piece is not in your strategic plan and you got to go back and figure that out as an organization, then the other part of that is and becomes, what is the game plan when the goal is not met at the end of the year? Again, the establishment of the new might look different than what it looks and sounds like in your respective organizations. Other hard.
Well, you mentioned something.
Oh, Shannon, I forgot you were going to go. Let me get Shannon, then I'll come back to Emmett.
Shannon is a short term.
And let me just say, as I am facilitating among two legends, I love that I get to control the mic. Shannon, I'm enjoying this as a product of this community. I'm bookended by two legends, and I'm getting to decide
talks. Shannon, and then Emmett. I know. Shannon, your time.
I'm still here for 2 months.
He's gonna use his time well.
I think one of the things we have to look at particularly is the issue of where we sit in this state in terms of our funding efficacy, for lack of a better word. We are the 4th largest city in the state, and our tax rate district-wide is, I think it's about 5th or it's lower than where we are percentage-wise. So the question is the burden that we have in our city. Do we, as a community, want to make the decision that we should be funding our services so that we can meet the needs that we've talked about? That's a hard decision to make and to vote on, but we should. Other communities that are larger than us have, make that decision all the time. It's difficult, but it's also something that we need to talk from a policy point of view. If we want to enhance services in mental health, if we want to enhance services in chronic disease, if we want to enhance services wherever, citizens vote. We're appointed here to make those type of decisions to carry to the court. And at some point, the court's going to have to make it, and especially now that we're in a period of time where the burden is falling upon local governments, we have to step up, or else we failed our own community. Now, I know people who don't like that, but that's the reality we live in. Or else, don't complain about the fact that you have all of these individuals who are sick on the street, are bothering you, but you don't have to pay to help take care of them. I think that's a dichotomy that we need to put out in the face of the public to let them know what we do and what a difference it makes. But it costs something, and short of doing that, we as a boards fail to put it in your face, sort of thing. So I just think that's a hard decision, but I think it's a decision that needs to be made and discussed.
Thank you. Emmett?
Well, I was going to say, I think you may have said that, something we need but can't afford. And a service we need and can't afford. And I think that's going to be pretty hard. Because you're saying we're building, and in the process of building, you come up with some things that you had not planned for, prepared for. And then you begin to hear some very specific things. It may not be widespread. It may only affect certain numbers of people. And for some thinking, that may not be enough to afford it.
Yep.
But if we're talking seamless systems of services, we need to work through that. And I think that would be hard.
And in the work of collaboration, when the need is so big, which by the way it is, huge need, right? There's a tendency to rush to a solution that can create other unintended challenges, right? So it's a hard place when you talk about the hard conversations, and I'm talking about like what are you possibly giving up to get. Those are going to be some really meaningful and needed conversations about what are we doing in the temporary for the greater good? How do we sustain it? What are the pieces that we need to look at that maybe we are not doing, and why? And when we say total care or patient-centered, care that's got all the stops, what are all the stops? And some of that discussion as it relates to funding will have to be what is the community that you keep naming willing to pay and buy into to do it, to make it happen. Anything else before we close out on hard?
Well, got 3 people, so.
Okay. Who's?
No. Let me just say, I feel like we've said what I've been thinking, but it is the juxtaposition of need against prioritization, and all these things we've been talking about are the priority setting parameters.
Yes.
One of the things, though, that I would expect from the teams, the people that are doing the work and presenting us, to your point about information, would be their expert opinion about the sequencing. Because sometimes, to Mom's point, you know what you need to do, but your funding is limited, so you have to sequence. You have to continually match up what your funding allows you to do to make progress on that plan. As they've said, it's never going to be perfect, it's never going to end. But we can be smart about how we prioritize what we have against what we're trying to accomplish.
Absolutely.
Yeah, and I kind of piggybacking directly on that, if you don't mind, Chair.
Okay.
I feel like if we were to make it, really simplify it, we've got this notion of mission, which is to provide care for the most vulnerable. So let's pretend, just with the magic wand, we squish the organizations together, just for simplicity. We still are in a world where we have finite resources and needs that eclipse those resources, to Trish's point. And so therefore, we are invariably rationing care. And through the lens of through whichever lens of ethical prioritization we use, we're going to have to make these decisions. And I would lean very much on, I was waiting a while to hear what Doc Martin was going to say, because I wanted to hear what the physicians and the medical practitioners in the room have to say about that, through the lens of morbidity and mortality, or like what are the lenses, adjusted life years, and how does that happen? And is there a framework that we could be given as board members, or if not given, are there frameworks that can be shared with us that we can, or even possibly co-create or merge or use to help guide those decisions? Because I don't think that rehashing that ethical framework every time is going to be constructive for us.
Right, so the opportunity is that there are plenty of frameworks, but it won't be a direct match because there are different indicators in the community that we're in, right? So there are pieces that you heard that were based on like best practices, and then a whole other part of like, that won't work here. So then that becomes the collective work about what does that look like? Even if we said qualitative, quantitative, whatever, there will still be a portion of that will have to be, that's not gonna be a perfect.
Fair enough. It'll be hard, but let's see what the baseline is.
Yeah,
to begin with, right?
I'm just gonna, I know we're going to wrap up. I'm gonna list two things that we haven't talked about that are hard. One is engage in the community, and I'm listing it as hard because I mean really engage in the community, figuring out how we're doing that. The second is sustainability, figuring out how we put structure in place that carries on into the future.
Okay, I gotta go back because you said engaging the community, and then you said really engaging the community.
Yeah.
Give me a little more context about that second part.
Engaging the community to me does not mean we make presentations at events in the community. That to me is not engaging the community.
Okay.
I don't have the perfect answer about what that means.
So not passive, not like tabling at an event. You mean engaging where we're listening, centering their voices in the work. Okay.
Go ahead.
Just on that note, there needs to be an accountability piece.
Yes.
And that is accountability to the community, to our taxpayers, to our board. So we need to find that accountability piece. And also in addition to that, there needs to be somewhat of aligned incentives for both entities to do the work. So I think aligning those, ensuring that you're incentivizing like integral care to refer whatever the patients to clinical services, as well central health. There is an incentive that they're referring them and ensuring the for behavioral health. So there needs to be that we can go into later on how we identify those points, but obviously the most important is that accountability piece is critical. So.
Awesome. Okay, we are 9 minutes over, so I'm going to conclude and just say that at the first piece of the follow-up will be you will get these notes back for which you can reflect on them, and then I will turn it back over to Trish and Ann for closing. But this has been I don't want it to be lost or not named, that this in and of itself for this community is a historic moment in time, if nothing else happens, because it has not occurred here. So really excited about the opportunities for you as you move forward. Thank you.
Hey, Pam, I'm going to add one more thing to your list. I'm sorry, I just thought of it. And that is how we engage the other stakeholders that need to be at the table.
Noted.
Okay. All right, so I'm going to close this out. Let's see. So we're moving on to our last item, which is confirm the next regular board retreat, board meeting date, time, and location. In terms of our next retreat, our next opportunity to discuss amongst ourselves, we'll figure that out. We don't have a date at the moment. And so at this time, I'm ready to accept a motion for adjournment. Moved and seconded, all in favor?
Aye.
Okay, we're adjourned.